set us behind as best as I can. Thank you so much to the organizers, Carl and all others, for the wonderful hospitality. And I will try to spend the next 45 minutes or so going over some of the concepts of how to try not to injure the lungs. You'll hear later on from Judy about how to deal with BPD and perhaps what causes it. I will try to see if we can cover some of the ways of minimizing it. We can't eliminate BPD, that much is clear, but we can always make it worse. And we have lots of ways of doing that. So I will try to deal with that. So as you can see from this alphabet soup here, we have lots and lots of different approaches, strategies, devices at our disposal in this very exciting time in neonatal respiratory care. And I will not be able to sort out all of this for you in the next 45 minutes, but I will try to address some key concepts of avoiding lung injury to the extent that we can. In order to do that, it's important to appreciate some of the important differences between preterm infants and older children and adults. As pediatricians, we all know that children are not simply small adults. And as neonatologists, we have to sometimes convince our subspecialist colleagues that newborns are not simply small children. Of course, we deal with some of these unique challenges, including the transitional circulation, which means oxygenation isn't simply about the lungs. The important issues of the chest wall, which is far too compliant, and this is really the reason why some assistance is almost always needed for the preterm infant, because their chest wall rigidity simply isn't sufficient to maintain FRC on its own. The chest wall mechanics are unfavorable. The preemies have limited muscle strength and endurance. They have immature respiratory control, which is important in how we ventilate them. They breathe rapidly. They have short time constants, which poses extra challenges on the equipment that we use. They're small. Their tracheas are small, and therefore the endotracheal tubes offer quite high resistance. And this is a significant issue that we need to recognize. We use uncuffed endotracheal tubes, which means there's almost always some leak around the tube, which makes tidal volume measurement a challenge. And we'll talk about that. So it is important, whatever we do, to always think in terms of the pathophysiology, because no cookbook prescription can cover all eventualities, and it is important for us to appreciate the physiology and the pathophysiology. And of course, what we're all trying to do, and I appreciate the fact that you can't see this, but this is a cartoon taken from a review article on lung injury that shows a nice, healthy, normal alveolus, which is air-filled, has a nice epithelium, healthy type 1 and 2 pneumocytes. And we're trying not to convert it into the severely injured alveolus, which is filled with proteinaceous fluid, is full of activated neutrophils and macrophages, which are releasing chemokines and cytokines and everything else, damaged epithelium, hyaline membranes, migrating neutrophils, and all of the other things that go along with acute lung injury, all of the things that can readily happen. And it turns out in a matter of minutes in the preterm infant, if we are ventilating in an inexpert and damaging fashion. So we'll try to talk about some of the ways that we can perhaps minimize this cascade of lung injury and subsequent repair that Judy will tell us more about. There are many different strategies one can employ to try to minimize lung injury, and certainly optimal DR stabilization that Anton talked so nicely about a moment ago is really key. And I'll just emphasize a couple of issues there as we go along. And it turns out that avoiding mechanical ventilation may be the most important thing that we can do. I won't spend more time about that, but there's certainly lots of things one can talk about in terms of non-invasive respiratory support. Surfactants certainly helpful. I will focus on avoiding excessively large tidal volumes and optimizing lung volume and avoiding atelectasis as the two perhaps most important strategy, secondary only to initial delivery room stabilization. There are other things that we don't have time to cover. But as Judy will tell you in more detail, BPD is a very multifactorial disease. There are lots of things that happen starting in utero that may affect lung development and may initiate the cascade of inflammation, lung injury, and subsequent repair already in utero. And there's not much we can do about that, perhaps. But the time of initiation of breathing, particularly in the preterm infant, is really a critical time. And it turns out that many of the interventions that we might be able to do will greatly impact on the subsequent need for all of these damaging things that happen when perhaps we had not optimized initial delivery room stabilization. And there is at least some evidence that these maneuvers, including certainly use of PEEP, but perhaps also the use of sustained inflation, some of the studies have indeed shown, as you heard, a significant reduction in mechanical ventilation, need for oxygen, and duration of oxygen exposure. And when you when you don't have to put in an endotracheal tube, your nosocomial infection rate drops quite substantially. So all of these things are substantially reduced by optimizing lung stabilization at delivery, and perhaps will therefore reduce the incidence of bronchopulmonary dysplasia, as at least the two studies that have compared sustained inflation to others have suggested. Now, we've become quite interested in the sustained inflation stuff, and we are actually in the process of a grant application to see if we can shed some more light on this subject. Just FYI, the question was asked about air leak. In the comparison studies, there was no increase in air leak, so that was somewhat reassuring. In any case, back to delivery room stabilization. I'm just going to show you this one slide, which many of you have seen before, and this simply indicates that it takes very little time to injure the lung, especially soon after birth. These are data from Lars Björklund from Sweden, I believe, where they exposed a subgroup of animals to large tidal volume inflations just before surfactant was administered. These were surfactant deficient animals who were given 6 rather large tidal volume inflations or not, followed by surfactant. You can see that the control animals had a nice response to surfactant, with a nice increase in lung compliance, whereas those who had whose lungs were injured by 6 excessively large inflations, that doesn't take very long, showed no response to exogenous surfactant, presumably because of outpouring of protein-rich fluid into the alveoli, which inactivated that surfactant. So one of the problems with all the studies that have looked at subsequent respiratory management is that none of them controlled what went on in the delivery room. And therefore, there may have been large differences, large influences that were not factored in. So as I mentioned, not ventilating babies is surely the best way to avoid ventilator-induced lung injury, but not all lung injury. And in fact, when you persist too long with CPAP and allow babies to flounder in high FiO2 with a lot of atelectasis, you will see an increase in air leak, for example, and you may not avoid all lung injury. But overall, clearly, we have all moved away from mechanical ventilation, and so what I'm going to talk about the rest of the lecture is becoming less widely used and largely applicable to the tiniest of infants who still require mechanical ventilation more frequently than not. So I will focus now for a period of time on the concept of avoiding excessively large tidal volumes, and I will talk about why we should worry about volume rather than pressure. I will, if you have any doubts about it, just show you one slide about how common inadvertent hyperventilation is. I don't think I need to convince you about the next point, which is that hypocapnia is bad for the brain, also for the lungs. And we'll discuss a little bit of some of the limitations of adult type of volume-controlled ventilation. So just to share with you a couple of studies, and none of these are very new. This information has been around for a long time, but largely ignored to the detriment of our patients. And this has to do with trying to distinguish whether pressure or volume is the primary determinant of lung injury. So here's one such study, and there are many others, that looked at in this case, capillary filtration coefficient as a marker of acute lung injury in animals exposed to escalating inflation pressures. But one group of animals had a plaster cast around the chest and upper abdomen, restricting chest wall excursion and therefore tidal volume. And in the other group, the lungs were free to expand. And what you see is that at low pressures of 15 centimeters, there was very little lung injury. But at 30 centimeters of inflation pressure, there was already a quite significant increase in lung injury over this very short period of time of ventilation. And at 45 centimeters, which of course is a very high inflation pressure, there was, not surprisingly, a very high degree of injury in the animals who were exposed to correspondingly high tidal volumes. But in the animals in whom chest wall movement was restricted and therefore tidal volume limited to a relatively normal value, there was no increase in capillary filtration coefficient, suggesting that it is not the pressure, they were both exposed to the same pressure, but the volume that determines acute lung injury. And so it turns out that pressure probably exerts its damaging effects through its effect on delivered tidal volume. And there's perhaps very low pressures may be safe, but a pressure of 20 centimeters, which would be thought of as safe by most of us, if in fact it is applied to a healthy lung, it will overexpand that healthy lung, which only needed a peak inflation pressure of perhaps 12 or 14 centimeters, and it will injure this healthy lung. So babies who are ventilated for brain injury, perhaps we can injure the lungs with what appears to be a safe pressure. Here's another study that many of you might be familiar with. Again, it's not new. It's been around a long time. Similar concept, looking at acute lung injury, essentially lung edema and protein leak into the alveolar spaces. Again, exposing rodents to a very high inflation pressure of 45 centimeters. And where the lungs were free to move, there is a high degree of lung injury. There was, similarly to the previous study, a group of animals who had a tight elastic bandage around the chest and abdomen, again restricting tidal volume. And you saw that there's a lot less lung injury in that subgroup. Again, exposed to the same pressure, but a more normal tidal volume. And the third group here, this is the addition or the more elegant part of the study, they generated very large tidal volumes with negative extrathoracic pressure. So they removed the positive pressure, inflation pressure issue here, but generated very large tidal volumes. And so it turns out that regardless of whether the large tidal volume was generated with a high inflating pressure or not, there was a lot of lung injury, and that regardless of the same degree of high inflation pressure, if the tidal volume is reduced, the lung injury is also reduced. So we really should be thinking of volutrauma rather than barotrauma, but we all grew up with the fear of inflation pressure as the biggest thing, and this barophobia is very difficult to get out of our brains, but we really should think in terms of tidal volume. But it's not as easy to do in neonates as it is in older subjects, in large measure because of the difficulties and challenges of measuring tidal volume. Well, we, for these reasons, many years ago adopted pressure-limited ventilation as the standard of care. But what happens with pressure-limited ventilation, of course, is that compliance improves, often quite rapidly. And when compliance improves and we're not standing at the bedside reducing the inflation pressure correspondingly, we will see an increase in delivered tidal volume and inadvertent hypocapnia. And here's an example. This is a study from a British unit, a well-reputed, very good unit, where do a very good job. Here, this was a study that actually tried to compare triggered and untriggered ventilation, and it did turn out there was no differences between the two. But what is striking is that around 30% of the babies on day 1 of life were exposed to these very low CO2 values, less than 25 millimeters of mercury. So this is quite a striking degree of inadvertent hyperventilation. And even on day 2, about 20%, and even on day 3, it was occurring in some babies. So this happens a lot. It happens because lung fluid is cleared. We give surfactant, we recruit lung volume, all of which improves lung compliance, and consequently tidal volume delivery increases. Well, if anyone had any doubt that low CO2 values are bad for the brain, here's an example also of how extreme the degree of hyperventilation can occur. This was the publication from Philadelphia with conventional mechanical ventilation, pressure limited, and there were babies who were reaching extremely low degrees of hypocapnia. And the lowest CO2 value was, the higher the incidence of bad things like cystic periventricular leukomalacia, severe grades of intraventricular hemorrhage, and cerebral palsy. So clearly, severe hypocapnia is to be avoided. But the question is how? Because as I told you, with pressure-limited ventilation, tidal volume can increase quite rapidly. But it turns out that the hypocapnia doesn't have to be that severe. Here is a retrospective study, a large retrospective study looking at hundreds of babies, and it looked specifically at the risk of severe intraventricular hemorrhage. And lots of things, it turns out, increase the risk of severe intraventricular hemorrhage. Mechanical ventilation by itself seems to be a culprit and doubles the risk of severe intraventricular hemorrhage. Well, perhaps it's just a marker, the need for mechanical ventilation, perhaps it's just a marker of a more immature baby, so maybe that's not the whole story. Well, it turns out very high CO2 values early on have also been associated with doubling of intraventricular hemorrhage. Again, these are all associations, not necessarily causations. What I found most perturbing, I apologize, this disappears, but the minimal CO2 value, less than 39, so not very severe degrees of hypocapnia, also more than double the risk of intraventricular hemorrhage. So these are all associations, but it suggests that it is probably a good idea to try to avoid excessively large tidal volumes, both from the standpoint of avoiding lung injury, but also avoiding brain injury. So why don't we do what the pediatric intensive care and adult intensive care doctors do, which is use volume-controlled ventilation? If we want to control tidal volume, well, we have machines that have that mode on it. Well, the problem is that what is controlled in volume-controlled ventilation is the tidal volume that is delivered into the proximal end of the ventilator circuit. And in adult and pediatric care, that works well enough because the patient's lungs are relatively large in comparison to the circuit and the humidifier, and the loss of volume to compression of gas and stretching of the circuit is relatively modest and easily compensated. In a small preterm infant, where the circuit and humidifier volume is several times larger than the infant's lungs, you get a lot of loss of volume to compression. And then we have the issue of endotracheal tube leakage, and that is very difficult to compensate. So it is not as straightforward. You can use volume-controlled ventilation in neonates, but it's best done with a proximal flow sensor here, where you adjust the tidal volume setting back at the machine to achieve an appropriate exhaled tidal volume at the airway opening. And the group of Sunil Sinha and Steve Dunn have demonstrated that this can be done, and it appeared to shorten the time to reaching extubatable settings and a few other factors. So there is some merit in doing that, but it is not as straightforward. The alternate approach is to modify pressure-limited ventilation in some fashion to try to control the delivered tidal volume. And this can be done in several different ways, and I'm not going to go through all the details, but essentially the two primary ways of doing this is to directly adjust the peak inflation pressure on the one hand, or to adjust the inspiratory time, essentially interrupting inflation if the volume limit is reached, and I'll show you how that works in a moment. Some use the exhaled tidal volume, some use the inspiratory tidal volume, and some of the devices control the tidal volume delivered into the circuit, which is again much less direct, and some control it based on the tidal volume delivered to the patient. So there are many complexities to this, and it's important that each of you understand the properties and the characteristics of your particular device and how it works and how to best use it, because there's lots of evidence in the literature and personal experience that it's not so much the device that determines our success or failure, but how well we use that device. So one of the basic algorithms that's in use, and it's in the servo, and a very similar algorithm also exists in the Draeger device and some of the other devices on the European and worldwide market that I'm not as familiar with, but essentially you can have initial breath, which determines some tidal volume is delivered, and then from that the device will compare the target tidal volume to the actual measured tidal volume and then adjust the pressure up or down or leave it the same if depending on how the tidal volume compares to the target. So pretty straightforward, and it works. In the servo device, however, what is controlled is the tidal volume delivered into the circuit, and so it's an indirect influence on the actual delivered tidal volume, and it's best to monitor the exhaled tidal volume. The volume limit function, which exists in several available devices, essentially works like any other pressure-limited ventilator. So you have the pressure waveform here, you have the flow and volume, and so you set a volume limit. Different names are used for these, but they are essentially the volume limit function exists in several of the devices I said. And what happens is, as long as the tidal volume is below the limit, it's just standard pressure-limited ventilation. If you get to the point where the tidal volume is reached, inflation is interrupted at that point. And it may be quite near the peak inflation flow. It may shorten the inspiratory time a great deal, and that may not be an optimal way of ventilating babies. And then the last problem is that if the compliance deteriorates, the volume limit function doesn't make any provision for achieving an adequate tidal volume. It only avoids an excessive tidal volume, which certainly is important, but hypoventilation is potentially also a problem. So here's an example from the Avia device of how the volume limit activated very early, near peak inflation flow, results in probably ventilating the airways more than ventilating the rest of the lungs. So there are some limitations to things. The mode that I'm most familiar with and that has been studied most extensively is volume guarantee. And you notice I put quotation marks around the guarantee word because it's actually an inappropriate name. The tidal volume fluctuates. It's not guaranteed. It's volume targeting using much the same algorithm as the servo, but using the exhaled tidal volume and using tidal volume measurement at the airway opening, which makes it a more accurate determination. There are several devices available in Europe, in addition to the Draeger device, that use essentially the same algorithms and the same principle of achieving tidal volume control, and that's all good. And one of the unique features of these specific neonatal ventilators is that they also have a separate control algorithm for triggered and untriggered breaths, and I'll probably skip over that, but this is just briefly to show you how tidal volume targeting works with the use of exhaled tidal volume to control tidal volume. The reason you use exhaled tidal volume is there is less leak around the endotracheal tube during exhalation, and therefore that tidal volume more closely approximates the true tidal volume that entered the baby's lungs. So so here's your pressure limit. So what you must do here with volume guarantee is select the pressure limit. Let me actually go back if I can find the up arrow. What you have to do here is select the pressure limit up to which you're willing to let the machine adjust the working pressure, the actual pressure delivered. You pick the tidal volume that you think is appropriate for your baby, and that is, it turns out, the most important decision that you make. And I'll talk about what tidal volume is appropriate under different circumstances. It turns out that one size does not fit all, which is increasingly a theme that permeates all of what we do. And off you go. And the device will then compare the actual tidal volume to the target and will adjust the pressure, the working pressure up or down, up to the pressure limit or down to the level of PEEP. And so if you set the target tidal volume below what the baby needs, the baby may be able to breathe above the set tidal volume, and the pressure will drop down to the level of PEEP, and you'll have a baby who's on endotracheal CPAP, which is not a good thing. So for long periods of time. So this is important, and it's important that we pay attention to all of these finer points. So these are the key decisions. Set the right tidal volume and then set a pressure limit, and you have to set a pressure limit that's high enough that the device can adjust up and down. And what happens is, of course, that it adjusts up and down in real time, not waiting for the next blood gas. And that turns out is important. So here we have the pressure limit. Here we have target tidal volume. And for simplicity, I only have the pressure and the volume curves here. So if the tidal volume is right on target with the initial inflation pressure, all is good. There'll be no change for the subsequent tidal volume. For the subsequent inflation, same pressure. But here, perhaps the baby breathed less vigorously because the tidal volume that's delivered and the reason why volume guarantee is always seeking but not always consistently maintaining exact same tidal volume is that with triggered ventilation, the baby and the machine work together. The baby is pulling air in, and the machine is pushing it in. And together they generate a transpulmonary pressure, the sum of the two efforts that result in a given tidal volume. So perhaps here the baby breathed less vigorously, and premature babies are notorious for having irregular and inconsistent and highly variable respiratory effort. So here the baby perhaps breathed less vigorously, and the tidal volume fell below the target. So for the next inflation, the pressure is adjusted upward in limited increments. It won't increase by more than a modest amount from breath to avoid overshooting. In this instance, let's say the tidal volume is back within a small percentage of the target, therefore no change for the next inflation. And here perhaps the baby now takes a more vigorous inspiratory effort of his own, resulting in a larger tidal volume. And as a result of that, the inflation pressure will be reduced for the subsequent mechanical inflation. Now, it is again important that we appreciate that this is all happening together. So if we go to the next slide, I want to simply emphasize the point that we do not measure the baby's contribution to each inflation, but here I drew it in and also added the flow. So here we have volume, flow, and pressure, inflation, pressure. These are the mechanical inflations, and here is drawn in the baby's inspiratory effort. And again, as I said, it is the transpulmonary pressure, the sum of the two, that determines the flow and volume. So here we have an immature small preterm infant with inconsistent respiratory effort. So the first two mechanical inflations are accompanied by spontaneous effort. They're triggered inflations, and they result in these tidal volumes. In this instance, the tidal volume was a little bit large, so for the subsequent inflation, the mechanical inflation pressure is reduced. Here the tidal volume is fine, so there's no change in the inflation pressure, but here the baby forgot to breathe. Or perhaps the frequency, the backup rate was set so high that the machine fired before the baby was ready to breathe, which is also a bad idea. So the backup rate should be slow enough, 40 or less in most babies. So in any case, if there is no contribution from the baby, the tidal volume will be much smaller. So because the tidal volume is below target, the inflation pressure is increased, but here the baby remembered to breathe again, and we have a much larger tidal volume than we would like. This is if there were not a separate algorithm, if there were just one. Right, and here the baby pauses for 3 inflations. It takes time for the pressure to adjust to finally come close to the target tidal volume, upon which point the baby wakes up again, takes a big breath, and we have an excessively large tidal volume. So this is the way it would be if it weren't for the clever engineers who said, aha, but this machine is designed for premature babies, so we're going to do something clever. We're going to look individually at triggered and untriggered inflations. So here is the same pattern of breathing, but this is with the Draeger baby log, where we have a separate algorithm, and I think some of the other devices do as well, but not all. And here, when the baby failed to breathe, the inflation pressure was one based on a previous untriggered breath, which is not on this, that's off the screen here somewhere before. And because this pressure is substantially higher, here the baby was accounting for almost half of the transpulmonary pressure. So as you saw on the previous slide, without the baby's contribution, the tidal volume was way too small. But here it's actually only a little bit small because the machine is using a more appropriate inflation pressure. Here the baby breathes again, and because the machine will look at the previous triggered breath, and since this tidal volume was appropriate, there will be no change in pressure, and the tidal volume isn't off too much. And here, the same breathing pattern, the baby fails to breathe for 3 inflations, but again, the machine uses the previous untriggered breath as its basis. So you can see that the transpulmonary pressure is a lot more consistent in this algorithm, the 2 separate ways of controlling, and the tidal volume fluctuates less. So it's important, these interactions between an actively breathing baby and the machine are quite complex, and it's unique to neonates because in the adult world and pediatrics, patients are usually heavily sedated or paralyzed, and they don't have these problems. But we know in neonates it's important to let them be awake and to make as much contribution as they can, and that reduces hemodynamic impairment and other issues and allows for respiratory muscle training. So it is a good thing, but it does make it more complicated, and we need to understand these complex interactions. So there are a fair number of benefits of volume-targeted ventilation in general. Most of these have been demonstrated with volume guarantee specifically, and they do maintain a relatively constant tidal volume. Not completely constant, and that's a good thing because completely monotonous ventilation leads to atelectasis over time, and that's one of the good reasons for not paralyzing or heavily sedating our patients. So they're always perturbing the equilibrium, and there's always some fluctuation around the target. But volume guarantee does prevent overdistension and volutrauma due to rapid improvement in lung compliance, as can happen with some of the things we talked about. And more importantly as well, it lowers inflation pressure in real time. It doesn't wait for blood gases, it doesn't wait for rounds, it doesn't wait for morning, it doesn't wait till it comes back from lunch like we do. It does it in real time. So not surprisingly, volume-targeted ventilation in general leads to shorter duration of mechanical ventilation, which is all a good thing. And it also compensates for the highly variable respiratory drive in a preterm infant who forgets to breathe or periodically hypoventilates and hyperventilates, and that's also an important function. But I want to return to the concept of the importance of optimizing lung inflation. And I will introduce that by this perhaps slightly puzzling statement that the benefit of volume-targeted ventilation cannot be realized without ensuring that that tidal volume is evenly distributed throughout an open lung. The open lung concept is key to prevention of lung injury. Merely controlling the tidal volume is only part of the equation. And why is that? Well, the reason, those of you who have been to IPOKRaTES before have seen this slide before, but it's very important. The reason is that maldistribution of tidal volume is key to lung injury. The lungs of an infant with RDS appear fairly homogeneous when you look at a 2-dimensional chest radiograph. But the problem is that we're compressing a 3-dimensional object, the lung, into 2 dimensions. And when you actually cut the lung crosswise, with a MRI or CT scan. This happens to be a sheep, I think, but, or perhaps a pig. You will see that much of the atelectasis is concentrated posteriorly with aerated lung anteriorly here. And there's a boundary between the two, and there certainly are shear forces where there's a lot of lung injury going on at this boundary. There's damage to the alectatic portion when there's outpouring of proteinaceous material which inactivates surfactant. There is other recruitment, de-recruitment injury going on here. But key to lung injury, perhaps more than all of these others, is the fact that whatever tidal volume we're delivering will preferentially go into the area of the lung that's already open. And we know this because of Laplace's law. We know that the atelectatic lung has a pretty high critical opening pressure. The smaller the alveolus, the more pressure is needed to distend it, right? That's Laplace's law. So the tidal volume will, in fact, primarily go here, and therefore even a normal physiologic tidal volume, when applied to only 1/3 or 1/2 of the normal number of alveoli, will in fact result in lung injury. So what we must do is try to get this lung uniformly inflated. It's not always easy to reach this state of perfection or nirvana, but it can be done, and a sustained inflation is one way to do that quickly in the delivery room and perhaps avoid some of the subsequent injury. That remains to be seen how effective that is. It's also important to appreciate that once the lung is recruited, it doesn't necessarily stay recruited if we do things like disconnect the infant from the ventilator, or even if you're in the delivery room, you've recruited the lung nicely, and now you're transferring the baby into a transport incubator. You disconnect the baby, and in front of your eyes, within seconds, the baby turns dusky. And the baby turns dusky because the lung de-recruited almost instantly. So anytime the nurses are repositioning the baby, or disconnecting, or God forbid, suctioning the baby, you will lose this lung recruitment, and you will, if you simply resume mechanical ventilation with a low level of end expiratory pressure, you'll probably get back to the lung injurious situation. So the lung can recruit fairly quickly. It takes longer probably to recruit it than it does to de-recruit it. And it's important to appreciate how quickly that optimal lung inflation can disappear. And here our previous speaker did a number of studies that addressed this open lung concept, including this one, which showed very nicely that it's probably not so much whether you use high frequency or low frequency ventilation, but whether or not you're using the optimal lung inflation concept. Here is, so this is a study in animals, surfactant lavage. This is an unventilated control. On the vertical axis is a lung injury score, a histologic score, so very low in those not ventilated, very high in those ventilated with conventional positive pressure ventilation, large tidal volume, relatively low end expiratory pressure. And we all know that oscillatory ventilation can reduce lung injury when used with the optimal lung volume strategy. And that's now become part and parcel of high frequency. And perhaps it is easier to optimize lung inflation with high frequency ventilation. But Anton and others have shown that you can achieve the open lung concept also with conventional ventilation if you use sufficiently high distending airway pressure. And there was the same degree of lung injury reduction in this study, and several similar studies showing much the same thing. So the benefits of high frequency ventilation may well primarily rest in its ability to achieve uniform lung inflation. I will briefly review a couple of studies from Gianluca Lista in Milan, who did 2 prospective randomized trials looking at volume guarantee. In the first one, he compared assist control with assist control plus volume guarantee, did bronchoalveolar lavage, and showed a reduction of pro-inflammatory cytokine levels, which are both markers and mediators of lung injury, and shorter duration of ventilation when he used a tidal volume target of 5 ml per kilo in these premature infants. He subsequently said, well, if 5 is good, maybe 3 is even better. So he compared 3 ml and 5 ml tidal volume target. But in those days, Gianluca was quite peepophobic. You know, you're all familiar with the concept of peepophobia, right? It's the irrational fear of using adequate distending airway pressures. he has changed his ways. He now fully appreciates the importance of PEEP and even sustained inflation. But in those days, he used PEEP of 3 to 4 centimeters plus low inflation pressures because of these very low tidal volumes. And as a consequence, there was a lot of atelectasis, validating again that even with a very small tidal volume, if you are allowing a lot of atelectasis to exist, you will injure the lungs. The concept of volume guarantee, has been studied somewhat extensively. This was the first small randomized trial that we did a number of years ago. And I'm showing this simply to point out that, yes, it does reduce excessively large tidal volumes and perhaps more importantly, drops by half the incidence of low CO2 values. But notice that it does not eliminate them altogether. There's a number of reasons for that. This is certainly an improvement over no volume guarantee, but it is not perfect for a variety of reasons that I don't have time to go into. Oh gosh, I hate when I do that. Let's see. And I'm going to skip over this slide because it's a little bit too complicated and we probably don't have time to go over it. I will show you just some, I know you can't read this, so you'll have to take my word for it, but no presentation is complete without a Cochrane meta-analysis, and this happens to be one recently published looking at several volume-targeted ventilation modes and modalities. This includes our study, Lista's study, and also the volume-controlled ventilation from Sunil's group. And it shows that duration of mechanical ventilation was reduced, and this makes sense because it is reducing pressure and weaning the level of support in real time without waiting for blood gases. So this is a very probable expected outcome. There was also an apparent reduction in the combined outcome of death or BPD at 36 weeks. This is a less convincing finding simply because BPD was not the primary outcome in any of the studies. It was not prospectively defined. In my study, we didn't even collect the information. They made me go back to the charts under a pretext and tell them what the BPD incidence rate was. I told them it's not really valid data, but here it is. And perhaps this is something we would expect. It is something that agrees with my bias, so I show it to you. No, it's a Cochrane review. It's gospel, right? Well, there are some limitations to Cochrane reviews. They obscure some important differences. But the incidence of pneumothorax was also reduced. Again, those of you not used to these graphs, anything that's to the left of the vertical line of identity and doesn't touch it means that there is a significant benefit to the intervention. So there was a reduction in pneumothorax, and again, this would be an expected outcome when you control the tidal volume. And a more recent review by Colin Morley also looked at and included some additional studies, looked at severe IVH and PVL, and showed those to also be reduced with volume-targeted ventilation. Again, this is a combination of PRVC, volume guarantee, volume control, but in principle, volume-targeted ventilation does appear to have some of these benefits. We are submitting a proposal to the network to do a volume-targeted ventilation study compared to pressure-limited, and we'll see if this is approved and goes forward to try to solidify whether these findings can be corroborated in a prospectively defined, well-done randomized trial. So there's a lot of other information. Volume guarantee specifically has been studied fairly extensively. I'm not going to go through all of these details. A fair number of these things were done in my group when I was at Georgetown. And as I showed you at my opening slide, I'm now at Brown University. I want to spend a few remaining moments, how are we doing? Yeah, we're good, on some of the clinical caveats, some of the more practical issues, because it turns out to be very important, and the tidal volume needs to be individualized for a particular baby, and I'll show you the data behind that. But just some basic caveats. I think volume guarantee or volume-targeted ventilation should be implemented as soon after birth as possible, because tidal volume compliance change most rapidly soon after birth. For most usual preemies of the garden variety, 700-800 grams, a target tidal volume of about 4.5 ml works quite well. A little bit smaller for the larger babies and a little bit bigger for the smaller babies, and I'll explain in a moment why that is. In really, really small babies, you need even larger tidal volumes. In babies with meconium aspiration, as opposed to RDS, you also need a larger tidal volume, as do babies with BPD. And the latter two conditions are those where there's an increase in physiologic dead space or wasted ventilation. And I'll show you some data about that. And you need to set the pressure limit, again, high enough so that the machine can adjust, because you're changing the control algorithm, you're changing the paradigm where before we fixed the pressure and the tidal volume could be whatever, sometimes way too low, sometimes high. Now if you want to fix the tidal volume and the baby occasionally breathes, sometimes not, you need to allow the device to adjust the pressure both up and down. So the pressure limit may look kind of high, but it's not being used most of the time. And remember, pressure doesn't matter, it's the volume that's the most important thing. So, but the pressure limit shouldn't be way, way higher than the working pressure, simply because, at least in many of the devices, the pressure will default to the pressure limit if you take out the flow sensor, if you use a manual inflation and other things, so it's important. And one of the things that volume guarantee does is it gives you an early warning, because if you have your pressure limit set close enough to the working pressure, if something changes in the tidal volume that previously was able to be delivered with a pressure limit of 20 or 25, now cannot be delivered, and you're getting constant alarms, low tidal volume, that means something might have changed. The compliance might have deteriorated, baby may have stopped breathing because he's getting septic, or you may have developed a significant leak around the endotracheal tube. And leak is an issue I'll get back to in a moment. So we have looked at a few things. This is in the process of being submitted, was presented at meetings. But here we looked at, retrospectively at a fairly large number of babies with different conditions, meconium aspiration babies being conventionally ventilated, and similar sized babies, mostly late preterm infants or term infants with more homogeneous disease like RDS or pneumonia. And what came to be, as we suspected. So we looked at what the tidal volume was when the CO2 value was in a normal range, that the control infants needed tidal volume a bit less than 5 ml per kilo, and babies with meconium aspiration needed tidal volume that was a bit larger than 6 ml per kilo, so about 20% larger, highly significant difference, yet and their minute ventilation was correspondingly even, in fact, a larger difference. So this was not just larger tidal volumes, but lower ventilatory rate, perhaps. They really did have a much higher total minute ventilation, but one has to surmise that their alveolar minute ventilation was the same because the CO2 was essentially identical. So this implies a lot of wasted ventilation, which of course goes along with the pathophysiology of meconium aspiration syndrome, where there's increased heterogeneity of inflation, a lot of wasted ventilation, in other words, increased physiologic dead space. So for this reason, we know that the starting point for meconium aspiration babies need to be larger. Similar factors play a role in BPD. But there's some additional issues as well that I'll return to in a moment. The issue of small babies versus larger babies, we have to recognize that in order to measure tidal volume accurately, you have to measure it at the airway opening. That means a flow sensor, and a flow sensor has a finite dead space. With the baby log, it's about 0.7 ml, fixed instrumental dead space. Well, for most babies, this is not a big deal, but as you might, if you think about it, it becomes clear that as the baby gets bigger or smaller, that dead space is a larger or smaller proportion of the total tidal volume. So big babies might do fine with a 4 to 4.5 ml tidal volume. Here we looked at all babies less than 800 grams, the extremely low birth weight infants. And we again looked at when the CO2 blood gas was within a normal range, what was the tidal volume. And as others have shown, it was about 4.5 to 5 ml per kilo for the 700-800 gram infant. When we looked at the lower end of the range, the ridiculously low birth weight infant, we noticed that the tidal volume was a bit larger on a per kilo basis. And again, it's because the baby's 800 grams, the dead space is an X proportion of their total tidal volume, right? And when the baby's 400 grams, it's twice as much. So clearly one would need to compensate a bit for that. But the reason we did this, we worried that many people take the flow sensor out of the circuit and ventilate these more vulnerable babies without the benefits of triggering, volume measurement, or volume targeting. We thought that was a bad idea. We in fact recognized that, and we measured the dead space, the total dead space, which includes the flow sensor, the endotracheal tube adapter, the suction adapter, the endotracheal tube, and it turns out to be about 3 ml. And it turns out that that's about the tidal volume that we were using. About half of the babies we were ventilating with a tidal volume that was no larger than the anatomical and instrumental dead space. That's, of course, not supposed to be possible. We all learned this physiology, right? That if you have, at the end of exhalation, the dead space, the part of the upper airway, or all of the upper airway is filled with CO2-rich gas, which is the exhaled gas. And that enters back into the alveoli with the next breath, and only a certain amount of fresh gas enters the alveoli. So if you have a tidal volume of 5 ml and a dead space of 3 ml, which I told you is with all the attachments we have, then you have only 2 ml of fresh gas entering the alveoli, whatever that means in terms of alveolar ventilation. If you now reduce the tidal volume from 5 to 4, only 1 ml of fresh gas would enter the alveoli, and the alveolar minute ventilation would be half of what it was before. And if your tidal volume is only 3, in other words, equal to dead space, then alveolar ventilation should be 0. But I just told you that half the babies we've, in fact, judged to be ventilated with tidal volume no larger than dead space. So what is happening? Well, we went to the lab to try to confirm or otherwise what we thought we saw clinically. And we had a setup with a little test lung, and we used a capnograph to measure the exhaled CO2. We filled the test lung with CO2 and began to ventilate it with different tidal volumes. And so if the tidal volume were less than the anatomical dead space, we shouldn't have any fresh gas. We shouldn't have any CO2 being washed out of the lung. So here you have individual breaths, and you can see the level is cut off at 150 because that's the limit of detection. But when you compress this waveform, many hundreds and thousands of breaths here, or inflations, this is a mechanical test lung, you see this flat portion, which is where this is cut off. But as CO2 is being washed out of the lung, the CO2 concentration, of course, drops, and therefore with each tidal volume you're removing less and less, and you have this nice exponential decline in the CO2 level, and at some point it levels off and reaches a lower limit of detection, and that's where we cut it off. And so the duration, the length of time it takes from initiation of ventilation to the end here is a good measure and a very reproducible measure of the efficiency of alveolar ventilation in a sense, or how much we're actually getting into that test lung. And it turned out that when we ventilated with a dead space plus 2 ml, just like I showed you in the diagram, it took about 100 seconds to get the CO2 level to drop to the lower limit of detection. We then reduced the tidal volume to only 1 ml above dead space, so it should have taken twice as long to remove CO2, but it only took a little bit longer. Now we're ventilating with tidal volume equal to dead space. We're still removing CO2, not quite as efficiently, but it's still coming out. And now we're ventilating with tidal volumes that are below the anatomical and instrumental dead space. And certainly it's less efficient, but clearly we're still reaching the alveoli, at least the inside of the test lung, and we are removing CO2. So what must be happening, of course, is that there is no piston, there's no hard boundary between the fresh gas and the dead space gas, and what we hypothesized that there must be fresh gas streaming through the upper airway anatomical dead space because of the viscous drag along the periphery here, and it turns out that the smaller the tube probably and the higher the flow velocity, the more of this spiking situation you have. During an abrupt stop, there's some radial diffusion, and then during exhalation, you probably get the same phenomenon in reverse. Well, we thought this was pretty clever, and this was published a couple of years ago, but it turns out nearly 100 years ago, a fellow named Henderson made a similar observation. It just fell into neglect. We knew for some time that this phenomenon probably happens with high-frequency jet ventilation, but it clearly also occurs with conventional ventilation rates, at least in small infants and narrow endotracheal tubes. Here I'll briefly show you some data with respect to babies who remain, this is the same less than 800 gram babies who remain on mechanical ventilation for up to 3 weeks. And this is the number of observations, so several hundred of pair observations each. And what you see is that when we started off with a tidal volume a little over 5 ml per kilo and PCO2 in the mild permissive hypercapnic range, we allowed the CO2 to rise into the mid-50s, as most of us do as the babies get older. But despite that, larger tidal volumes were required, up to a little over 6 ml, and they were much more variable. The standard deviation goes up, and this has to do with the greater heterogeneity. Some of these babies were needing 7 or even 8 ml per kilo. Again, these were the ridiculously low birth weight infants who have the dead space issue. So there's several things that are going on. One of them clearly is increased physiologic dead space because of the heterogeneity of inflation with BPD. But there's also an increase in anatomical dead space as the trachea dilates. If you ventilate a baby with SS control with a rate of 60 per minute, that's 86,000 inflations in a day. And that's a lot. And many years ago, Vinny Bhutani and colleagues showed that babies, very small babies who were mechanically ventilated, had a larger tracheal diameter than those who were not ventilated. And of course, that translates into increased anatomical dead space. This slide is just to remind me to point out that with the new Babylog VN500, where you can use the corrected tidal volume measurement, we've learned that the assumption that the exhaled tidal volume is a pretty good approximation of the real tidal volume turns out to have been too optimistic. And we're now finding that when you use the corrected tidal volume, which gives you the real tidal volume, correcting for the leakage, and this is a basis for the algorithm, and I won't go over that, but just to point out that some of you may be finding that the new ventilator doesn't work like the old one did, and it's really because you've been ventilating with tidal volumes larger than what you thought, because the leak that you have makes a tidal volume that you think is 3.5 or 4 actually be 4.5 or 5. So keep that in mind, and if some of you are having that experience, that's the likely explanation. So I'm about finished. I will just point out a couple of things here. You don't want to lower the tidal volume too much during weaning, because you're then making the baby breathe through a narrow endotracheal tube with very little assistance from the baby. You obviously want the baby to have a respiratory drive. You want the pH to be low enough that the baby has a respiratory drive. And if you do that, the pressure will come down on its own, but the volume the baby needs does not come down. The volume, if anything, may go down if the baby's now been on the ventilator for a while. And I'm just going to show you 1 or 2 bits of data from Anne Greenoff's group, where her group looked at different levels of tidal volume targeting with a different ventilator, but same concept. And what she found was that the work of breathing, the higher the tidal volume, the lower it was, and the lower the tidal volume at the low end, 4 ml per kilo, it was significantly higher than at baseline. And even though here they were targeting a 4 ml per kilo tidal volume, the actual tidal volume the babies were generating was closer to 5. In other words, the baby said 4 is not enough. We need more, but we're not getting any help. So we have a high work of breathing and we're tachypnic. So there is an optimal tidal volume. If you set it too low, if you're trying to push the baby too hard, you may actually handicap them and they may become exhausted, develop atelectasis, and in fact not succeed. Here's an example from another study that showed sort of the same thing, shifting the work of breathing from the ventilator to the baby. Here is volume guarantee combined with SIMV, and with SIMV you do need a somewhat larger tidal volume. Typically the tidal volume is about 6 ml per kilo with SIMV. So this was the baseline, and the baby was doing about half the work of breathing. When Carmen started the volume guarantee at 4.5, that was a reduction in the target, so the baby had to pick up the work, and that's to a degree that's appropriate. So in yellow is what the baby is doing, in red is what the ventilator is doing, and here is the sum in green. And when she further reduced the tidal volume target to 3 ml, which is too low, the babies were doing virtually all the work. There was very little help from the ventilator, and the babies were becoming exhausted. So don't lower the target way too much. I'm going to skip over that because I think we're more or less out of time. And I will also point out that we still have a lot of unanswered questions. Specifically, or more so in BPD and other significant situations, lots of studies are needed, but research, particularly clinical research, requires quite a bit of resources, and those are hard to come by, so I've had to resort to unconventional means of raising funds. So thank you very much.